Let me, before I start on this, put this in perspective. To me, it's a very important session that you've just been listening to. This is the growth engine in the vascular surgery world at the moment. As long as you know how to diagnose and treat varicose veins, you're never going to starve. There's an insatiable demand out there. And it's not cosmetic. And I'm going to tell you my story in this respect, is that because my legs would be aching when I'd be standing operating. And I don't have varicose veins. So walk over to our vascular lab and I said, scan my legs. I had wide open reflux. And so I said, okay, I want them ablated. And so I go to one of my partners, Eric Peden. He happened to take vacation when Bootcamp was on. That's a whole nother story. So you're not going to hear from Eric. And so I said, ablate my veins. He said, what do you want done? I said, well, this is an opportunity of a lifetime to resolve the long-standing controversy in vascular surgery, venous radiofrequency ablation versus laser ablation. So I got the laser glasses on, got the iPhone in, we said randomize my legs, use one on one side and one on the other. And so I got to go to these meetings and I hear these guys debate over it. They know nothing about what they're talking about. And I'll get up and say, you're just full of it. Okay? Let me tell you from a consumer standpoint, and said, first of all, the procedure is nothing. Secondly, when you take the dressings off after 2 days, I was black and blue, literally from ass to ankle on one side, and that was the laser ablation side. The radiofrequency ablation side, both of them will work perfectly, transforms how your legs feel. So when we basically poo-poo what a patient is going through, makes a big difference if you're going to be standing and your legs are aching, but I'm a radiofrequency ablation guy to prove it. And now, lastly, the pulmonary embolism stuff that you've heard about it is another really interesting area that we as a vascular group, our capability is to flex to where the new devices and the new treatment opportunities are, and it's something that we're working on pretty hard, is interventional pulmonary arterial therapy. So last but not least, we're going to talk about arteriovenous malformations. And again, these patients need a home. They're often maltreated because nobody really knows quite what to do. This is like MEN1 syndrome for general surgeons. You ain't ever going to cure this. These patients are going to be, you need a vascular home, they're going to be coming back for life, rarely can you cure them, and they need interventions, and they're often basically mistreated. And so this is a patient of mine who's on with the leg side, he's got Klippel-Trenaunay syndrome, he's got an absent deep venous system, and he's got venous malformations. And so he, it's kind of interesting, these keep flicking off, because it's showing on the monitor back there, but it's completely blank up here. And so what happens, there you go, thank you. And so the way you categorize these on the patient's left, as you're looking at it, that's venous, okay? On the right, it's a combination of arterial and venous. So the first categorization is it arterial or is it venous? Is it mixed? It's always mixed to some extent, but some of them are almost pure venous. And then there's a third component I'm not going to talk about at all, is the lymphatic component. Sometimes you're convinced they've got an AVM and there's no blood vessels, and it's usually lymphatic under those circumstances. So these are the ones that we're going to see. And so one of the questions is, what happens, the manifestations of these things are legion, because they can occur anywhere. Most common ones you get are inside the brain. We don't see those, but you can see them in the neck, you can see them in the trunk. Those can be particularly difficult. It can be basically in the mesentery, it can be in the legs. And so the concept of these, they're congenital, and some of them are static, and some of them basically grow. There are certain things that tend to make them grow. Trauma can make them grow. Pregnancy tends to make them grow. Going on oral contraceptives can sometimes make them grow. And basically the idea is to try and define the arterial side of it, the venous side of it, and the so-called nidus where they communicate. And if you can get, it's kind of this nebulous, I've never seen a nidus yet. Everybody else talks about it, and it's this kind of idea. Basically it means you get your catheter as far out in the arteries as you can, and then you start blocking them off at that point. So the symptoms can vary depending upon their location. You all hear about, they say, heart failure from shunting. I've seen that once. Those are massive arteriovenous malformations in order to be able to get that. Sometimes you can get neuromuscular pain because it is in and around a nerve. Sometimes you can get tissue ulceration. Sometimes you can get hemorrhage. More often, it is local discomfort and deformity that you're actually going to be dealing with. And so there's certain absolute, and you don't have to treat these. If your patient's come along 10 years, they've got a little lump in their arm and it's not bothering them, you don't even need to touch it. But there are certain indications to go ahead and do it, and that is basically if it's bleeding, if it's ulcerated, occasionally there's ischemia from steel, not very often, occasionally there's heart failure. Most of the time, it's localized pain, claudication, if you take that off there, that almost never happens, but functional impairment and neurological involvement can take place. And so there are a variety of different ways in which you're going to manage these patients. If it's just it's local discomfort, you may be able to palliate it in the same way you treat varicose veins with stockings and limb elevation. If it is localized, and so you use MRI really to define where it is, you're really trying to see how close to the axial structures like the nerves, sciatic nerve, or the artery of the vein it actually is. If it's localized in the muscle group, that's the one situation you've got an opportunity to excise it. And we have an AVM team. We have a particular plastic surgeon basically to work with, orthopedic surgeons less so. It's mainly going to be us and the plastic surgeon who work with it. So take it out if you can take it out. Sometimes you've got to embolize it before you can take it out. You can't cure them basically with embolization. And one of the cardinal rules for you is don't ligate the major feeding vessels. So for example, I had a patient who had a big pelvic AVM and some person had ligated the internal iliac artery. Fortunately, he couldn't even do that very well. And so there's a little hole coming down through the middle of it, and first thing we did was put a wire across it, balloon in it, blew off his silk so we could actually get down in there. So you're not doing the patient a favor by ligating major feeding vessels that are going in there. And there's certain concepts really in treatment. You've seen some of the previous examples with coils. Coils are not really the way you're going to treat the majority of these patients. Most of the arteriovenous malformations, you're going to use either onyx. Onyx is like lava, okay? Then there's glue. We've almost entirely switched from using the glues because they're difficult to use, they're hazardous. You really got to, and you can glue the catheter in place over onto onyx. Onyx was really developed really for intracranial venous malformations. It gives you time, and you can slowly advance it basically into the center of the arteriovenous malformation. So using flow-directed therapy is really the way you're going to get into these super small vessels. And so the concept is super selective access. It challenges your endovascular skills because you don't want to just stick it in the superficial femoral artery or a little side branch. You want to get out through that side branch and far out as you can get. PVA particles are largely not going to be used. Almost all of this stuff basically has been replaced with using onyx basically or glue. Sometimes in the very high flow malformations, when you start injecting things, it just can fly through it. And those are the situations that you may use big coils in the big vessels to slow the flow down, but not to block them, because you want the catheters that are going to go through the coils out into the more distal vessel to actually block them off. I'm not going to go into the embryo. There's a bunch of different ways in which you can classify these. Although this classification doesn't help us one iota, it's how much of it is AVM, how much of it is venous, and what is the anatomy in terms basically of the approach that you're going to use to this. MR is probably the best way really of defining this. It will show you the nerves very well, and it will show you the distribution basically of the arteriovenous malformation. And sometimes, the locations are so variable, it's hard to generalize, but really we're looking to see the adjacency to vital structure. I worry a lot about embolizing AVMs that encompass the sciatic nerve, for example, because of the potential risk basically of damage to these. Here's a situation where this was a localized arteriovenous malformation, and we plan our operation based upon this. The rectus femoris, you can see the AVM really is deeply placed in there, and we just go ahead and excise this entire thing. It's not really that bloody as much as you would think it would be, and then we just put a couple of drains in there and close it up. And so this patient presented with pain. Embolization, again, the rules in embolization are bad things happen fast. Good things happen slowly, okay? I tell them we're going to do this multiple times. We're going to embolize, because what happens is you've selected, you come down through the axial blood vessel. Let's say basically it's the SFA, and you're going out a vessel that's feeding in on the arteriovenous malformation. As you start blocking off the flow, so your embolic material starts backing up. And so if you inject hard and you've occluded the distal circulation, it goes backwards into the SFA and it shoots down the leg, and you just turned a good case into a great case, but unfortunately you're going to be there for hours trying to suck that stuff out of there. So again, commit basically to doing this multiple times and be very selective in terms of how you're going to embolize these things. Most of these patients have to go to sleep because some of these embolics basically hurt them when they actually introduce it, when you actually inject it, particularly, for example, glue hurts. So safe steps for safe embolization, good preliminary angiography. You need to map everything out. And again, another example of this is a carotid body tumor. Think of it as an arteriovenous malformation. And as you start occluding part of the tumor, so you start finding that the embolic material moves through collateral pathways. Now there it can be critical to be able to see that you're not embolizing into the posterior circulation. So these unusual collateral pathways start becoming more and more important as you take out a significant part of the arteriovenous malformation or the tumor circulation. So you want the catheter in a stable position. You don't want the catheter to be backing out basically as you're injecting it. Doesn't really happen very often with Onyx. One of the new developments with Onyx is there's a thing called a scepter balloon, which you can position right at the origin of the target vessel, and it doesn't get stuck in the onyx, and so it pushes the onyx and protects the axial circulation. So you're always looking for these collateral pathways, and you're looking for non-target embolization. Now, one of the best tricks, and I mentioned to someone outside that we work with our neuroradiologists, you can't get Onyx without, and talking to one of your neuroradiologists, they won't ship it. And so it's very useful to have one of them basically as your colleagues, and they'll teach you a lot, because what happens is you inject an Onyx into a big old cluster, so it becomes opaque, and then you can't see the new Onyx that's going in there. So what you do in that situation is use your roadmap function. So you inject the Onyx, and on the roadmap, it subtracts out the old Onyx that's in there, and now you can see where the new pathways are that you're actually injecting. So never be afraid to work with people. I learn more from people working with people who are not vascular surgeons now than people who are vascular surgeons. So it's really good to kind of work with people. A lot of these things basically we've talked about. Bottom line is it's mainly coils for big blood vessels, and it's Onyx really almost exclusively for us now, basically to the small vessels. And that's kind of what the bottom right is, that giant AVM where we use these coils to slow it down, and then we injected Onyx into it. On the venous side, if it's a venous malformation, pure venous that you're dealing with, think of them as just being pure big varicose veins. There we treat these patients with sclerofoam, which is sodium tetradecyl sulfate, 10 cc's in one syringe connected with a three-way stopcock, 10 cc's of air in the other syringe, where you make foam. And so it makes these big bubbles that you actually inject into the venous malformation. Now, we have the luxury of Zolt, who you heard from earlier, who's doing transcranial Doppler. So if we're doing that, usually during the first 1 or 2 injections, we do continuous transcranial Doppler monitoring to make sure there's not a PFO. Because you inject some of their strokes have been described associated with doing this, and it's because of a patent PFO and the sclerosant transits from right side to left side. So that would be one of the situations you might think about putting a tourniquet on, put the patient head down. In fact, you always put the patient head down when you're doing this, and just make sure that there's not any evidence basically of embolization going on up into the head. The other thing is sometimes do is inject these things directly. And one of the recently we had a young kid came up from Mexico, and he had Amplatzer plugs sticking out through his skin because he had been embolized there, and they were all rolling through the skin, and he had an intrahumeral AVM. Again, one of our radiologists came up, put in a transosseous needle straight into the middle of his humerus, and we went ahead and embolized him. So you can stick these things directly. Carotid body tumors, our preferred approach now. We were always told carotid body was the most vascular structure out there. You can't do a biopsy and you can't stick it. Well, the new technique is stick it. Most of these things that you're taught of as dogma probably are completely wrong, and you'll change it. The reason what reminded me is we recently had a patient with a hand AVM. The radial artery and ulnar artery were occluded, and she had all these collaterals. There was no direct access. You can puncture these things basically directly and inject or dye into them. So this is another example basically of intraosseous arteriovenous malformation. So to conclude then, I believe these patients lack a home. I think they're technically very challenging, and that's the kind of thing we're interested in being involved in. The IR basically, there's many who do a good job in this, but they tend not to basically follow up these patients kind of the way that we do. There's no single therapeutic option, so you need to be aware basically is it surgical excision. If possible, that's the way we're going to get first of all. Sometimes they're not even in the place. The way I get a patient who's got one high up on the inside of her thigh. There is no access to it other than fuse the images and stick a needle directly into the arteriovenous malformation. 3D imaging, the whole guide to this basically is imaging. Evaluate for involvement of vital structures before we go injecting them. Observe repeated embolization, excision if possible. Rapid growth of excellent imaging really basically helps us. So there's my term. It's the MEN1 of vascular surgery. You're going to be your patients for life, and they're very grateful. And for those of you who are interested, there's great research, clinical and teaching opportunities around this, because by and large, everybody sees 1 or 2 of these patients and they need a place to be seen.